Well, hello USA faculty. My name is Kinnan Lewis and I'm one of your Texas colleagues. And thank you for taking the time to go through this PowerPoint presentation, which is really looking at an update for pain science. It is in preparation for a faculty development session, which is on the 1st of July. And you should also have received some references that were forwarded by Dr. Patler, as well as a very entertaining introduction from Lorimer Moseley. You may ask, why do I need an update? And I think that most of us have not maintained a contemporary knowledge of pain science. I know myself that I had very little education in pain science in my undergraduate degree. I graduated in 1993, and there was some discussion of the spinal gating theory of Melzack and Wall, but probably not too much else. And there's been a really huge growth in the knowledge of pain and management of pain, and hopefully this will bring you up to date if you're not already up to date. So pain has been defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So this is an imperfect definition, but it does have a couple of good aspects to it. It does recognize that there are psychosocial elements, and it also recognizes that pain is not directly proportional to tissue damage, and that it can actually occur when we simply have potential tissue damage. So it really is rejecting that Cartesian notion of pain, and we'll talk about that a little more as we go through. Pain is always subjective. It is universal. As I'll quote Mark Knopfler, no one passes through these swinging doors without leaving some blood upon the floor. We all have pain, and we all have a different experience of pain. And of course our experience of pain varies depending on context. Pain is very complex, and I think you may be more aware of that at the end of this presentation. Hopefully that's so. I think it's useful here to divide pain crudely into acute and persistent. One, acute, is really thought to be in most cases beneficial, while persistent pain is in many cases pathological and causes dysfunction and disability. Pain can be a disease symptom, but it also can itself be an impairment. Pain can definitely be frightening, and that frightening aspect of pain can cause stress, and we know that stress can then amplify the pain experience. And then to make it even more complicated, pain can even be pleasurable. We do have people who are masochists, and it just makes pain that much more interesting. Why should we understand pain? Well, it's the primary reason for physical therapy consultations, and I'm sure it, in many other allied health settings, is also a very important reason for consultations. It is a symptom of many medical conditions, and even if we have a biomedical approach, unless we treat pain, we're not effectively going to be able to treat dysfunctions and disabilities. Pain is extremely costly, and America is all about money, and if we look at the annual cost of persistent pain alone in America, it's around about 635 billion. So there are really good economic reasons for us to understand and manage pain better. Now, pain has been inadequately addressed in healthcare, and there are many reasons why this may be so. It is rarely life-threatening. It is invisible. We really can't know how much pain someone is in. We can infer it from their behavior, their posture, but we really don't know. Pain, I think you'll agree, is poorly correlated with imaging. We can have people with advanced changes on imaging who have very little pain, and conversely we can have people with very little apparent imaging changes who have severe pain. Another reason that it's inadequately addressed is because it's difficult to treat, a particularly persistent pain, where we can't really stay with the biomedical model and go for a cure. We really have to look at management. And the other reason that it's been inadequately addressed is there's been a lack of sufficient education in health science curricula. And this has really been researched widely by Watt Watson. Now, this is a fanciful comparison, but there are parallels between human flight and the human understanding of pain. And it's been said that we've learned more about pain in the last 10 years than in the preceding 1,000 years. And it's interesting to look at the similarity in the timelines for human flight and human understanding of pain. So for example, the biopsychosocial model was proposed in 1977, just 8 years after we took our first steps on the moon. So let's talk about flight. So pre-flight planning, and here's a sketch of one of Leonardo's flying machines, and you can see the position of the test pilot here. I'm not sure if I would have volunteered, because it looks as though it involved a flapping component, and that's really not in keeping with today's hang gliders. If we look at pain historically, it was initially attributed to gods and demons, and it was really Hippocrates, who's regarded as the father of modern medicine, who made a big breakthrough in recognizing that disease was not due to gods, but in fact was due to our lifestyle, the environment we were in and what we ate. He was also advanced in that he recognized that the role of a healer has a social dimension, and that is to help patients cope with their suffering. So he really was recognizing psychosocial elements back in 370 BC. Plato was a Greek philosopher and mathematician. He didn't believe that the nervous system was at all involved with pain, and that the heart and liver were the centers of all sensation. And his student Aristotle also confirmed that pain had no role in pain sensation. Well, how wrong they were, I think we can forgive their mistakes. So the first big leap for flight was, I guess, the first powered flight by the Wright brothers at Kitty Hawk in North Carolina in 1903. And this is a great black and white image of one of the Wright brothers flying and one watching. For pain, René Descartes was really the person responsible for the first great leap. So he was a French philosopher, mathematician and writer, and the first one to recognize the role of the nervous system in pain perception. He also believed that the brain was a center of processing for pain, but he did believe that pain was only a transmission from peripheral to central, that there was no modulation, and that pain was really proportional to the extent of tissue damage. And of course, therefore, a corollary is that when that injury has healed, pain ceases. Now, Descartes must have himself realized that there were limitations to his model. For example, why do we have pain in an absent limb that has healed? The stump is healed. Why do we have pain? Why do we have persistent pain after there's been plenty of time for healing? Why do we have pain with innocuous stimuli? Descartes must have known of cases in war where horrific injuries were sustained without immediate pain. And we are all aware of the contextual variability of pain, how when we're feeling depressed or negative, we can feel more pain, and when we're feeling positive, buoyant, we tend to have less pain. Despite these limitations, this model was really held until the middle of the 20th century, and for some people really it's still held. And there is also a reversion to this Cartesian or biomedical model, and we see this in medicine, in interventional pain medicine, where injections are used without addressing psychosocial aspects of pain, and also the implantation of spinal cord stimulators. So the big leap that followed next for flight was the first man in space, and here we have Yuri Gagarin, sadly not an American but a Soviet, who was a Soviet test pilot and the first man in space. I think he succumbed to alcoholism and then had a motor vehicle accident, and so he had a tragic end. The big leap that corresponds in pain science is with Melzack and Wall, who proposed their gate control theory. They, as most of you probably would be aware, they postulated that transmission through A beta fibers, these large myelinated fibers, could inhibit at the spinal cord transmission through C fibers, these thin unmyelinated fibers, as well as A delta fibers, the thin myelinated fibers. And these latter two were and are considered to be the main fibers involved in transmission of nociceptive impulses. So they postulated that A beta fibers interfere with the transmission of these nociceptive fibers at the spinal cord. What's often forgotten, though, is they recognized that there were descending inhibitory pathways also modulating at the spinal cord. And we can see this illustrated in this diagram here. So we have here your small fibers, your C and A delta, and we have here large myelinated fibers, and we can see here that they're both converging on the spinal cord, but we have also a excitation of interneurons by these large fibers, which then has an inhibitory effect on the smaller fibers. And you can see too in this diagram that the descending inhibition is also represented here from higher centers. We should acknowledge Patrick Wall and Ronald Melzack, who really have contributed so much to our understanding and management of pain. So Ronald Melzack, I believe, is still alive, a Canadian psychologist trained at McGill University, and it's he who was involved in developing the McGill Pain Questionnaire that is used in our physical therapy curriculum quite widely in the musculoskeletal area, and I'm sure is used in occupational therapy as well. Patrick Wall, who is now deceased, he was a British neuroscientist from Oxford University, and he was instrumental in developing the TENS unit. And we're very fortunate that they collaborated at MIT in the 1960s and co-wrote Pain Mechanisms: A New Theory. So from their work, we come to this threshold concept that pain is always an output of the brain. And even now I struggle with this, that it does not hurt at the site of injury, at the site of tissue damage. We only experience pain when the brain concludes that the body is threatened, and it is in no way proportional to tissue damage. So really this Cartesian model is completely rejected. The third leap for flight, I guess, is the first steps of man on the moon in 1969. So quite amazing when you consider that the first powered flight was in 1903. We had 66 years later a man on the moon. And I thought that this quote from Butler and Mosley was very apt. We can put a man on the moon. Why can't someone just fix this pain for me? And this frustration is often expressed by patients. We have all this technology. Why do I still need to experience pain? Well, the big leap for pain was the biopsychosocial model. So this was proposed by Engel, an American psychiatrist who coined the term, and it was really a formal recognition that there were biological, psychological, and social components to the experience of pain, that it was a multifactorial experience, and therefore we really needed to treat our patients holistically and consider psychological and social aspects of their life. The next leap that I'll propose for flight is the International Space Station. which was initially sent up in 1998. It was the Mir station originally, of course, so that was Russian, and it's ironic now that we're reliant on Russian rockets to travel to and from the International Space Station since the US dropped its shuttle program. For pain, the big leap was the neuromatrix concept, and again, this was Melzack, so Ronald Melzack. And this really included implicit recognition of the biopsychosocial model, and Melzack spoke about the neuromatrix, which I define as an integrated network of neural centers that contribute to the pain experience. So this is really looking at the somatosensory parts of the nervous system, the limbic system, so this ancient part of the central nervous system that's involved with emotion and fear, and then the thalamocortical, really the stress and cognition part of the central nervous system, and they're the main networks that are involved in the experience of pain. This concept recognized that pain was multidimensional, that there were genetic factors and there were certainly memory influences that were involved, and that pain could be modulated by thought processes and by sensory input. It also really stressed that stress was a key factor in the experience of pain. And this concept has really been very highly influential in physiotherapy, physical therapy, and really has directed the work of Lorimer Moseley and David Butler, who have been champions in Australia for pain science and intervention. Also in the neuromatrix concept is this neurosignature. So this is my definition, the unique combination of contributions from neural centers that constitute a pain experience. So it's also been termed the neurotag by Butler and Moseley, and perhaps a good way to illustrate this is to give you an example. So I'm not going to go through this in detail, but you can see that really we're looking at here different areas, different higher centers that are communicating, and as a result we have in our perception of pain such aspects as problem solving, concentration, fear, memories. They're all being incorporated into this process of determining whether we're going to perceive pain and to what degree. We have some evidence for this neuromatrix concept, and that's come through magnetic resonance imaging, where we can actually view the function of the brain as we cause pain. We also have quantitative sensory testing, also termed psychosensory testing, where we can again cause painful stimuli through pressure, electrical current, hot and cold, and less so through vibration, and they can tell us about the different fibers that are involved in the sensation. So let's now talk about the different aspects of the biopsychosocial model, beginning of course with biological. So this is really what we're used to. This is the biomedical part of the biopsychosocial model. So here we're looking at pathoanatomy, really, as well as tissue injury. We're looking at inflammatory process, and we are in here also considering peripheral and central sensitization. Let's talk about peripheral sensitization. So this starts with tissue damage, and it can be mechanical, it can be thermal, it can be chemical. We get then a release of inflammatory mediators, so these are neuropeptides, and many of you will be familiar with different inflammatory mediators. As a result of that, we then have changes in nociceptors. So we get an increase in the number of nociceptors, but also we get an increase in the number of transducers that convert the injury to sensory transmission. These also become increasingly sensitive. so the activation thresholds are decreased. Additionally, we have recruitment of dormant nociceptors. So we have in the spinal cord polymodal fibers that can really transmit with mechanical, thermal, or chemical detection of damage. Central sensitization is a result of sustained nociceptor activation. So this really can be defined, and Wolff defined it as an amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. And there are different manifestations of that, and we'll talk about that in a moment. But other processes that are involved in central sensitization are sensitization of dorsal horn neurons. So these are particularly wide dynamic range neurons. We get recruitment of A beta fibers. So these are usually involved with transmission of vibration and touch, but they can now become recruited as nociceptors, as transmitting danger sensations, or danger impulses rather than sensations. We get decreased pain inhibition from higher centers. So these are descending tracts, and endogenous opioids are really involved in this kind of modulation. And we get a loss of opioid receptors, meaning that these endogenous opioids are less effective. We also get an increase in pain facilitation from higher centers. So these are descending tracts that facilitate the transmission of nociceptive impulses to the higher centers. We get changes in the neuromatrix, so an altered representation of pain in the brain. So, for example, areas of the brain that are involved with fear and memory may have more of an influence as we get this central sensitization. We have changes in the sensory homunculus. So this is the virtual representation of the body in the brain, and we have an enlargement for the injured region. So we have a greater area of sensory cortex that is devoted to that injured region. We also have smudging, so we have a loss of the delineation between body parts, and this causes spread of the region in which we sense pain. So this is illustrated here, and again from Butler and Mosley. We have, for example, injury to the little finger, and in the sensory cortex we have a loss of delineation between the fifth, the fourth, and the third fingers, so that instead of pain being only experienced in that little finger, we now have it experienced more generally in the hand. Also involved in central sensitization are other mechanisms, particularly modulated by stress. So stress causes an increase in sympathetic tone, which then causes release of adrenaline, or in America known as epinephrine, and this makes us anxious. It decreases parasympathetic tone, and that reduction in parasympathetic tone causes then a reduction in tissue repair. So this is the aspect of the autonomic nervous system that we can think of as rest and digest. We also get, with this adrenaline, an irritation of the dorsal root ganglia, and therefore increased sensitivity of nociceptors, and also antidromic impulses. So these are from the spinal cord to the periphery, and unlike orthodromic, these impulses are able to cause further release of inflammatory mediators. In addition, stress can modulate through the thalamus-hypothalamus. We can get release of cortisol from the adrenal glands. This cortisol can again inhibit the parasympathetic system, so decrease tissue repair, but it can also cause the production of cytokines, which are immune molecules that can then cause inflammation, sensitivity, and as a result increase nociceptive input. So it's a very complicated process, and if you've read that article that was sent out by Gatchell, you'll have an idea of the complexity of the biochemistry of this process. So peripheral and central sensitization can be manifested as hypersensitivity in different ways. We can see hyperalgesia, which is where stimuli that were previously painful become more painful. We can have allodynia, where previously innocuous stimuli now become painful. So for example, light touch can become painful. We can have temporal summation, and this really refers to the pain felt when we have repeated stimuli that were previously innocuous. Alright, so I think that the big leap for flight, and not just for flight but for human technology, will be the Mars colony. The big leap for pain is the clinical application of pain science, and really we're faced in physical therapy, occupational therapy, and really generally in medicine with challenges, and these are, particularly with pain, the need to reduce the likelihood of recurrent pain, the need to reduce the likelihood of acute pain becoming persistent, and then the difficulty in treating persistent pain. I see those as really the big challenges for us clinically. We need to recognize the role, the key role, of physiotherapists, physical therapists in multidisciplinary teams. We need to cooperate with physicians, with psychologists, with dietitians, and with occupational therapists to really address the three aspects of this multifactorial experience of pain. Let's talk about some strategies for the clinical application of pain science. The first of these is really self-education, and I would strongly recommend that everyone read Explain Pain. And not only read, but mark, learn, and inwardly digest, to quote William Shakespeare. This was put out by Butler and Mosley in 2003, so it is somewhat dated, but in many ways it's current, and it's a very good introduction to management of pain, particularly persistent pain. We need to embrace the biopsychosocial model, so recognize that there are these different aspects of pain. We need to not only recognize but assess the contributions and then address those contributions. For the biological part of the biopsychosocial model, it's very well covered in our curricula, both PT and OT, and in the MOE curriculum that's been developed. We need to ensure that we are using evidence-based or informed practice. So this is really dependent on the three pillars of the best available evidence. Research is really needed to be current. We want then expertise and experience for the clinician, and then we also need to consider the expectations of the client. So this derives from the work of Sackett, who described evidence-based practice as the integration of best research evidence with clinical experience and patient values. So if we look at the social aspects of pain, we need to consider education, family background, work environment, culture, the current and past history for conditions, and also the expectations of our clients. And I provided an example for each of these different categories on this slide. We need to identify as well as assess the psychological component for a pain experience. So we have different tools for this, and these are just a few, but the pain catastrophizing scale is a good one that has been validated and is reliable. We have the fear avoidance beliefs questionnaire developed by Waddell. It perhaps doesn't look at social aspects of pain perhaps as much as it ought to, but it's a useful tool. And for post-traumatic stress, we have the impact of events scale. And as I said, there are numerous other ways to assess pain with self-report. And of course, this is then also tempered with what we see and perceive during our assessment. If we identify psychopathologies, we need to refer to experts who can deal with these. So problems like depression, post-traumatic stress disorder, they need to be referred to a psychologist we need to recognize that we are not the experts in this area, and that we have people who can help. With our psychological intervention for pain, one thing that's really been shown to be effective, it's not level 2 evidence, probably level 3 evidence from Moseley, is that providing education in itself there's education for pain, science and management can in itself be effective for reducing the experience of pain. We need to remind our patients that pain is not proportional to damage, and that hurt does not equate to harm. That if they have a persistent problem and they have increased pain, it doesn't mean that they have necessarily regressed in terms of their tissue. We need to remind them that pain occurs when the brain concludes the body is threatened, and that it's an essential experience, and it's really our brain attempting to protect us, even though that may be pathological. It's really the brain trying to protect us. We need to recognize the power of cognition, and that thoughts are just like nociceptive impulses, they are nerve transmissions. We need to, for our patients, identify and acknowledge their fears. We need to be very careful with our language to avoid emotive language that might engender fear and stress that could then amplify pain. And particularly, we need to be careful when we are translating and interpreting imaging reports, where words such as advanced, degenerative, chronic and severe are used. We need to translate those into terms that are less threatening and less likely to cause stress and therefore pain. I would encourage all of us to embody a placebo and not a nocebo. So we want to be an influence that helps and not harms. And to do that, we need to accept that pain is genuine. We need to show that we are interested and committed in helping our patients, and we need to be empathetic and show compassion. We need to be honest but positive, and we need to demonstrate competence. This idea of resilience was provided by Sullivan and Lin just this year, and this was to do with management of acute pain, and using such phrases as, look, your disc is really very strong and it's unlikely you've done permanent damage, and then reminding patients that their body has a great capacity to heal itself. We need to foster this resilience to help with management of pain. There are also other psychological techniques we can use, and really some of this is cognitive behavioral, if we look at it as an overarching umbrella term. But graded motor imagery, virtual body exercises, there's good evidence for these being effective for management of certain persistent pain conditions. Pacing and graded activity, again, really graded motor imagery is a form of graded activity, can also be helpful, but perhaps not by itself. It really needs to be combined with other forms of intervention. Relaxation techniques in themselves have been shown to be effective for management of pain, and really they're probably operating by reducing sympathetic tone and increasing that parasympathetic tone. We need to ensure that our patients have sufficient sleep, and that's again to do with sympathetic and parasympathetic tone. Now, I hope this PowerPoint has been helpful. This is my first voice-over PowerPoint, so please be forgiving, and we'll see you for the faculty development on the 1st of July.